Good morning. So today is 3rd October 2020. We have started the lectures on this optics and refraction. Today we are going to learn something about an error of refraction, that is myopia. So up till now we have studied in optics and refraction what is visual acuity, what are the properties of light, optics of the eye, reduced eye, how the light is focused on the light sensitive layer of retina. Then we have studied something about the mirrors, that is spherical mirrors, then concave and convex mirrors, and in the lenses, convex lens and concave lens and cylindrical lenses. In the last lecture we have studied something about retinoscopy, how to arrive at a diagnosis of a refractive error in a patient. So the state or the status of the eye will give the retinoscopy reading accordingly. So as per the distance, that is arm's distance or 2/3 of a meter, we are deducting the. Also, if we have done a retinoscopy with a weight retinoscopy, that is mean use of a cycloplegic or a mydriatic, we are deducting that value from the retinoscopy reading. And we are doing that subjective correction, that is called as a post-mydriatic test. So in dry retinoscopy we are giving the refractive error correction on the same day, and in wet retinoscopy we are giving the refractive error correction, subjective refractive error correction as per the drug used. In atropine we are taking a long time. So just to recap, light is stimulus for vision. When there is a light, we can see the things. They are the reflected light from the objects. The light is perceived by the object and it is reflected, and our retina, we are having an optical component and neurological component. So focusing of the object will be done by the optical component, and analysis of the image is taken at the higher function, that is at the visual cortex. So the cornea accounts for about 80% of the focusing of an image, and the lens which adjusts its shape, that is called as accommodation, that is for another 20%. So light rays pass through the lens more sharply and focus near objects on the retina. So this is how an image, in this picture there is a cup, that is an object, and it is focused on the retina which lines the back of the eye, that is light sensitive layer, and we are seeing an inverted image of the cup. So we will see how the focusing of light rays occurs in the eye. So in this picture we are seeing the rays, object is far, so rays coming, parallel rays, they are coming from the far away distance. We have taken it is more than 6 meters. So rays of light coming from a small light source, that is more further than 20 feet away, are approximately parallel. So the focus point for parallel light is at A on the retina. In this picture it is shown that the parallel rays, they are focusing on a point, that is A. The eye is slightly hypermetropic according to the picture. Then moving an object closer pushes the focus point back. What it means? When the light rays are parallel, the eye is not in an accommodated state, the lens is flat. But as the object is moving closer to the eye, what is happening? If the lens has not changed its shape, the image of an object will fall behind the retina, that is point B. So moving an object closer to the relaxed eye pushes the focus point back. Then what will happen again? So if you want to focus the point, near point on the retina, the lens has to increase its shape. So increasing its shape, that is accommodating the extra power, that is called as accommodation, you will focus the near object on the retina. So accommodation of the eye increases the focusing power of the lens and brings the focus point for a near object back to A. So we have seen the 3 slides. On the first slide, the parallel rays, they were focused on A. In the second slide, the rays which are coming from a near object are not focused, but they are focused on the back of the eye, that is B. And if you want to focus again on the retina, the lens has to increase its size. So the common name for refractive error is nearsightedness or short-sightedness. Patients with myopia are known as myopes, so we are studying this myopia. Just we have studied how the focusing of an image occurs in the eye. So short-sightedness is a type of refractive error in which parallel rays of light coming from infinity are focused in front of the retina when accommodation is at rate. So this definition is important from your viva point of view. In your clinical viva, the examiner can ask you a definition of myopia. Inability to see distant objects clearly, that is the main symptom. So what is myopia in Greek? It means I close the eye, half close the eye. The first satisfactory definition of myopia was given by Kepler and Lemphis. Myopic patients form 20% of the population and are dependent on optical aid, hence make the majority of the patient visiting ophthalmic clinic. So from Government of India, we have made a plan that is called as a school eye health. So catch them young. So from the school eye health, the paramedical ophthalmic assistant, they are visiting the schools and they are screening the child. So generally, if they are found having a problem in their visual acuity, they are referred to the ophthalmologist clinic. So in this picture, you are again seeing how the image of an object is formed. So image is focused in front of retina, that can be caused by refractive myopia. Cornea or lens bends too much, means curvature of cornea or the lens is too much, so the light or bending of the light is more, so the light falls in front of the retina. Then another variety is axial myopia. If the eyeball is too long compared to the normal due to imperfect immetropization, so again because of the increase in the length of the eyeball, the light rays coming from far away, they will fall in front of the retina. So parallel rays of light come to focus in front of the retina. The furthest point at which the object is seen called as a far point. In immetropic eyes, it is at infinite distance. For myopic eye, it is at a finite distance. So there are three pictures, that is A, B, C. The rays coming from far away, you are taken as a more than 6 meters away, they are focusing on the retina. Then for the B picture, the rays coming from a near object, again in an immetropic eye, they will fall on the retina. This is called as a far point, where you can have a good quality vision. And in C picture, the rays coming from far away, they are focused behind the retina and they have to be focused on the retina. So these are the three things that can occur while focusing of an image. So image can be on the retina, immetropia. Image can be in front of the retina, that is called as a myopia, and image can fall behind the retina, that is in a hypermetropia. And you are correcting this refractive error by the process of neutralization. In last lecture we have seen. So what is the optics of myopia? Image of distant object on the retina is made up of the circles of diffusion formed by the divergent beam. Since the parallel rays of light coming from infinity are focused in front of the retina, far point of the myopic eye is a finite point in front of the eye. Nodal point in a myopic eye is further away from the retina, image form will be larger. Etiological classification. So in your theory examination, we can have a question describe the refractive errors, different types of refractive errors, and write about or describe myopia, types of myopia, classification of myopia, or treatment of myopia. So from theory point of view also, this is a long question, or you can have to write a short note on simple myopia, pathological myopia, or myopia only. So from the etiological classification or varieties of myopia, they are axial myopia, curvature myopia, index myopia. So axial myopia, this is due to increase in anterior posterior length of the eyeball. So 1 millimeter increase in axial length will cause a 3 diopter. So that is a -3 diopter of myopia. 1 millimeter increase in axial length. So just like reverse, if there is a decrease of 1 millimeter in the axial length, that will cause a 3 diopter of hypermetropia. Curvature myopia, it is associated with increase in curvature of the cornea or lens. So again, the curvature, if there is a 1 millimeter variation in radius of curvature, is associated with 6 diopter of refractive change. That is astigmatism. In index myopia, it is because of the refractive index of a crystalline lens associated with nuclear sclerosis. So refractive index means the speed of light in the medium compared with the speed of light into the vacuum or in the air. So if the light has to travel through a thick medium, its speed decreases. So in index myopia, the crystalline lens has a different refractive index as per in the center or in the nucleus or in the cortex. So that is the index myopia. In positional myopia is produced by anterior placement of crystalline lens in the eye. So in some of the condition, when there is a subluxation, you can have, if it is an anterior placed crystalline lens, you get a myopia. Myopia due to excessive accommodation. It means it occurs in patient with spasm of accommodation. In this patient, if there is a spasm of accommodation, the lens is a bigger in size. So the light will fall in front of the retina. Then what are the types of myopia? So we can have a congenital myopia, simple myopia, pathological or degenerative myopia. Acquired myopia may be, as per the books, post-traumatic, post-keratotic, drug-induced. Then you can have a pseudomyopia, space myopia, night myopia, and consecutive myopia. So we will see what is a congenital myopia. It presents since birth, diagnosed by 2 to 3 years. Mostly the error is unilateral and manifests as anisometropia. Error is 8 to 10 diopter, mostly remains constant. The child may develop convergent squint, that is also called as a esotropia. Congenital myopia may sometimes have cataract, microphthalmus, aniridia, megalocornea. These are the associated findings. Full cycloplegic early refractive error correction is desirable in such cases. Then we are seeing another variety, that is a simple myopia, that is the commonest, considered as a physiological error. Its prevalence increases from 2% at 5 years to 14% at 15 years. Normally what happens in a child who is not going into the school, as he is playing, he will be attracted to only the near objects. And as there is no problem in the near vision, the child will not complain about the deficiency or difficulty in vision or diminished vision at the distance, because even watching the TV or mobile, that is from the near distance. So his everyday core activity are without any difficulty, so the child is not complaining. And so the government of India has planned a school eye health program for the school going children. So we are screening the children at the schools after the age of 5 years. 29% is having low myopia, that is less than 2 diopter, and 7% moderate myopia, that is 2 to 6 diopter. That is simple myopia. Simple myopia results from normal biological variation in the development of eye. Axial type may signify just a physiological variation. Curvature type of simple myopia due to underdevelopment of eyeball or more curvature of the cornea. What is the role of genetics? The genetics plays some role. Prevalence of myopia is more in children with both parents myopic 20%. If one of the parent is myopic, then it is prevalence is 10%, and no parent myopic is in the child can have a myopia that is in 5% of the children. What are the clinical features of myopia? The poor vision for distance, asthenopia, half shutting of the eyes. Because of the half shutting, it can cause a pinhole effect, and the child will have a good quality vision. So he will be having all the time shutting of the eyes and squinting. What are the signs? These are prominent eyeballs, deep anterior chamber, slightly large pupils. Then fundus is normal. Simple myopia error does not exceed 6 to 8 diopters. Then pathological myopia. This has been covered by Dr.Rajesh sir, our HOD. High myopia they have covered, but just to have some few lines. Pathological myopia is a degenerative and rapidly progressive error which starts in childhood at 5 to 10 years, increases steadily, results in high myopia during early adult life, associated with pathological eye condition like vitreous degeneration and retinal degeneration. Pathological myopia results from a rapid axial growth of an eyeball, linked with hereditary and general growth, racial predilection. Elongation may be due to primary degeneration of coats of eye, including posterior of sclera. In a high degree of myopia, sclera may bulge at posterior pole, that is called as a posterior staphyloma. So this can be a question examiner can ask, name me the staphyloma that is in sclera. So you should know the varieties of staphyloma and what is the definition of staphyloma. That is from your viva point of view. So genetic factors causing retina, growth of retina, then stretching of sclera, choroid degeneration, retina and vitreous degeneration. This can go in formation of myopic. These are the myopic factors. Role of general growth process, that is a minor role, but to name a few: nutrition deficiency, debilitating diseases, endocrine disturbances, they may have some role in the formation of myopia. Defective vision, error is high in high myopia. Musky voluntarities, that is a floating black opacities in front of the eyes. When the patient sees a bright area or looking at the sky, they can see this floating black opacity. They are called as a musky voluntarities. Night blindness because of the marked chorioretinal degeneration. Refractive errors, 4 diopter, stabilized at age 20 years, frequently results in myopia 10 to 20 diopter, even progression to 30 to 40. In this picture you can see the eyeball has elongated behind the equator. So eyes, they are prominent, cornea is large, anterior chamber is deep, pupil slightly larger in myopic patient. In fundus, you can see optic disc that can be large. There is a temporal edge, supertraction crescent, degenerative changes in retina and choroid. It looks a fundus called as a tigroid fundus. Later, you can see white atrophic patches. Tigroid or tessellated is the name given for this myopic fundus. Then you can have Photorefractive spots, that is hyperpigmented fibrovascular scar, cystoid degeneration, lattice degeneration or snail track lesion. And in this high myopic patient, there can be a complication of retinal tears, retinal hemorrhage and detachment. The tigroid fundus, just I mentioned, tessellated fundus. There are visible prominent large choroidal vessels following atrophy of retinal pigment epithelium and choriocapillaries. Complications in myopic patient, high myopic, that is retinal detachment, complicated cataract, vitreous hemorrhage, choroidal hemorrhage, strabismus fixus. What are the clinical features? Optical symptoms are defective far vision. The child holding the books too close to the eye while reading generally doesn't go out. He will be interested only in the indoor play games. Then there is a discomfort after near work and black spots may be seen floating in front of the eye. The non-optical symptoms, they can have a musky voluntous, sudden central scotoma due to macular hemorrhage, that is Fuchs spot, acute drop of vision due to retinal detachment, gradual drop of vision due to either complicated cataract or macular degeneration. In pathological myopia patient or high myopic patient, we are not allowing them to have sports like boxing or diving because there should not be increase in the intrathoracic pressure, intra-abdominal or intrathoracic pressure. In some books they have written they can be called as a cause of a retinal detachment, sudden increase in the intrathoracic or intra-abdominal pressure, and some sports are not for these high or pathological myopic patients. In myopic patients, in ophthalmoscopy, you can see changes at disc, that is myopic crescent, changes in the central area of fundus, that is chorioretinal scar or macular degeneration, you can see. Then there is a big optic disc, nasal supertraction, annular ring, atrophic patches, choroidal sclerosis, posterior Fuchs spots. This has been covered by Dr. Rajesh sir. So in a tablet form, simple myopia, degenerative myopia, congenital myopia, you can very well remember this table. Simple myopia is commonest, starts around puberty, stops at 21 to 25 years, usually less than -70. No degeneration is seen. In degenerative or pathological myopia, starts in childhood, progresses till the age of 31 to 35, that is called as a progressive myopia, maybe up to 30 diopters. Degenerations are common, and in congenital myopia, dated since birth, and it can be about -10 diopter. Then what is the treatment for this myopia? So correction of myopia is done by placing the minus lens in front of the eye. The minus lens with whose second focal point is coincident with the far point of myopic eye will correct that eye. It means the child can focus an image from the far point of the eye. The myopic eye will have a far point in front of his eyes. So any object is, if at the far point of the myopic eye, then its image will be focused on the retina, and this is the principle of treatment. Minimum acceptance providing maximum vision. In very high myopia, under correction is better to avoid the problem of near vision and magnification of image. Optical lenses guidelines, prescription of appropriate glasses, myopia never overcorrected, simple myopia up to 6 diopter fully corrected. So this is how we are giving a treatment. So correction of myopia by glasses, you are giving a minus lens that will diverge the coming parallel rays, and again they will be focused on the retina. Then you can have a contact lens that is also causing this focusing up. So there is a change of the versions. So the rays which are converging has to be made divergent and again focused on the retina. So this is the principle. So in this picture you can see a myopic eye, means there is a axial length is more. So the parallel rays coming from far away, they are focused in front of the light sensitive layer in front of the retina. So the distant objects appear blurred. As the spot of light is moved, after, in the starting lecture I have shown you these 3 slides how the focusing of image takes place. So if you are taking the object near to the eye. Means as the spot of light is moved closer to the eye, the focus point is pushed back until at the far point the rays are focused on the retina. So object is coming near and near. So the focusing point on the retina will recede back. It means it will be in front of retina to the retina. So the principle is that from the far point the object is seeing, it means you have to make a lens such that the objects or the image will be at the far point of the eye. So in this picture you can see they have termed it as a corrective lens. So the parallel rays, when they are passing through a corrective lens, will make an image of an object at the far point of the eye. And as you know that the child or the patient can see the objects clearly from the far point. A corrective lens which bends light so that it enters the eye at the same angle as the light coming from the far point. It brings light to a focus on the retina. Angle A is the same in B and C. So this is the far point. In this another picture, there is a focusing of image for far point to the retina, and you have to make a corrective lens of a such a type that the rays coming from an object has to be focused at the far point, so the patient can see the objects clearly. Again, this is a picture. So the object is this is a green leaves, 3 leaves. So the rays coming from this, as they are passing through a concave lens, it will have a divergence effect of the rays. But the rays, when they are converged backwards, you can have a virtual image in front of the eye. And again, that virtual image will be seen by the eye because that virtual image is at the far point of the eye. Another modality of treating the myopia patient is a contact lens. That is useful. It eliminates peripheral distortion. So you have to mention these additional benefits of contact lenses over the spectacle. That is also the question in aphakia. What is the importance of advantage of intraocular lens over aphakic spectacles? Just to mention, this is for your viva point. Then another, that is low vision aid. In pathological myopia, progressive myopia with advanced vision changes, glasses or contact lenses seldom improve the vision to normal. So low vision aid may be of help. So this contact lens and low vision aid, they are different topics to be discussed. Then what is the surgical treatment of myopia? The question can be a refractive surgeries for the treatment of myopia. So there are cornea based procedures and lens based procedures. So there is a radial keratotomy, photorefractive keratectomy, laser in situ keratomyolysis, that is customized and EPE LASIK, intracorneal rings, and orthokeratology. These are the cornea based procedures. Then there are lens based procedures for the treatment of myopia, that is for surgical, refractive lens exchange and phakic refractive lens. So we will just see what is cornea based procedures. First is the radial keratotomy, now it is optical. But to just know the history, 4 to 8 deep but not penetrating radial incisions are made in the cornea. The central 2.5 millimeter zone, that is called as an optical zone, that was spared. When these radial incisions heal, the central zone will be flattened, and this operation is usually used only in simple myopia because it corrects only 3 to 7 minus diopter myopia. So it was used previously, but there are complications of this radial keratotomic procedures, so that is not done nowadays because more nice and non-traumatic or non-invasive procedures are available, or you can have with laser surgery and safe surgery. So in radial keratomy there were 16 or 24 incisions. They were made on the normal cornea with a diamond knife, and as just mentioned, the central zone was made to flatten, and so the rays will be focused on the retina. Making deep radial incisions in peripheral part of cornea, leaving the central 4 mm optical zone, and after the healing this central cornea was flattened. But the disadvantage in this radial keratotomy procedure was cornea is weakened, globe rupture can occur, uneven healing. Generally you are not certain about the healing procedure, so you can have irregular astigmatism, and the patient may feel glare at night if you have not maintained the optical zone. So the light will be reflected and refracted at the edge of this scar. So the patient may feel glare at night. Then post-surgical complications in radial keratotomy, there was a hyperopic shift, diurnal fluctuation of refractive error, glare and corneal scarring. Then there is another procedure that is called as a photorefractive keratectomy. The high energy photons from excimer laser are used to photoablate. So these are the property of laser photoablation. The small amount of tissue from anterior corneal surface, and there is culting of the cornea. It corrects up to 6 diopters of myopia. So you are changing the structure of cornea, altering the structure of cornea. Excimer laser removes layers from the cornea in order to achieve a proper curvature. So the first is laser in situ keratomyolysis, that is called as a LASIK. In LASIK, the superficial corneal layers are incised by a special machine, that is keratome, and the laser is applied to the stroma. Flap of 130 to 160 micron thickness of anterior corneal tissue is raised. Mid-stromal tissue is ablated directly with an excimer laser beam, and this causes the flattening of the cornea in the center. This is the way. There is a flap of cornea has been raised, and the excimer laser beam is applied into the center of the cornea. The stroma is flattened. There is another variety that is called as customized LASIK, that is based on wavefront technology. It corrects spherical, cylindrical and other aberrations. Then there is a EP LASIK, that is advances in LASIK. You can have only epithelial sheet is separated with epikeratome. They are devoid of complications related to corneal stromal flap. Advantages of LASIK: minimal or no post-operative pain, recovery of vision is early compared to PRK, no risk of perforation, no residual haze. LASIK is effective in correcting myopia of -12 diopters. Disadvantage of expensive, requires greater surgical skill, and there are some flap related complications, that is intraoperative flap amputation, wrinkling of flap, post-operative flap dislocation, epithelialization of flap, irregular astigmatism. The patient selection criteria for the LASIK surgery, this can be asked in your viva also. The patient should be of more than 20-21 years. The stable refraction for at least 1 year. The patient should be motivated. There should not be any corneal pathology. The absolute contraindications for LASIK are presence of ectasia and corneal thickness that is less than 450. Corneal thickness is measured by pachymetry. Then there is another variety, that is intracorneal ring into the peripheral cornea at approximately 2/3 stromal depth. You are inserting these corneal rings, so there is a flattening of the central cornea. that decreases the myopia. It is a reversible procedure. Lens based procedures, they are refractive lens exchange. There is an extraction of clear crystalline lens. This is again I have a question. Somebody can ask you what is Foucault's operation. So removal of clear crystalline lens in high myopia of -16 to -18 diopter in unilateral cases. The clear extraction, but nowadays we are not doing only clear extraction, but we are implanting an intraocular lens. Even that can be of a 0 power. So appropriate power refractive intraocular lens, that is called as a refractive surgery for myopia of more than a 12 diopter. This is a refractive lens exchange. Then there is another one surgical procedure for myopia, that is a phakic lens implantation. This is called as a phakic refractive lens or implantable contact lens. It is correct for the correction of myopia of more than 8 diopters. There is a placement of a special intraocular lens in the anterior chamber or posterior chamber anterior to the natural crystalline lens. So it is in front of the natural crystalline lens. This is natural crystalline lens is not disturbed, it is not removed. This is called as a phakic lens implantation. Intraocular contact lens implantation for correction of myopia of more than 12. Then there is another procedure that is called as a orthokeratology, a non-surgical reversible method of molding the cornea with overnight wear unique rigid gas permeable contact lenses. It will cause a myopia correction up to -5 diopter, used in patients below 18 years of age. Then there is genetic counseling. Just we have seen what are the problems. Pathological myopia has a strong genetic basis. Hereditary transfer of disease may be decreased by advising against marriage between two individuals with progressive myopia, and we can go far that even they marry, they should not have children. So genetic counseling is important also in high myopia or pathological myopia patients. So herewith we have covered this refractive error, that is myopia. The next topic will be hypermetropia and then astigmatism.